MCL, the classification, so we went through a little bit of mechanisms of injury and fussed about with a couple of the other things and didn't really get to prognosis, but we'll work our way through it. Mechanism of injury is a valgus stress to the knee, and then sort of we thought about high and low energy injuries, where in high energy you're suspecting other ligamentous injuries, and in low you're just looking at an isolated injury. On the examination, we're looking at fusion, medial tendon, so femoral insertion, because that's where it most commonly pulls off, and then valgus stress at 0 degrees and 30 degrees. So if it opens up in 0 degrees, then you're suspecting other ligaments being injured as well as the MCL, and at 30 degrees, isolated MCL injury, depending on how much it opens up. And then check ACL, PCL, and lateral collaterals. But don't do a pivot shift because it won't work with a MCL deficient knee. Investigations, look at plain X-rays and MRI if it's a high-grade injury. The classification that we looked at was grade 1, 2, 3. No laxity, or 0 to 5 millimetres with an endpoint. Grade 2, opening 5 to 10 with a firm endpoint. And grade 3, opening greater than 10 millimetres. And then the management, a hinged knee brace we had a little bit of discussion about length of time, but 6 weeks. Weight bearing was tied during that time. And then grade 3, possible surgical management in a multi-ligamentous injury. And we didn't quite get to prognosis. But generally, an MCL injury, as an isolated injury, would have a good prognosis.
Just go back a couple of slides. Right, I'll just everyone take that in. Is everyone happy with that? Would everyone agree with that? Very reasonable. So that's grade 1, 2, 3 of the MCL. Does it relate at all to what happens in flexion and extension?
Yes, so you shouldn't have any opening of the in valgus stress, the grade 1 or 2 in full extension.
Can you get a grade 3 MCL and have no opening and extension?
No. I don't think so.
Isolated MCLs is what we're talking about. They've been well studied in the lab and clinically because they're so common, and the basic science is actually fairly well reported, and they tend to heal well non-operatively. So I think we're chucking around the terms MCL, and the important part is what actually is the MCL. So there's 2 parts to it, but then you get into the idea of a medial complex, so not just the medial collateral ligament. So there's actually 3 parts: a superficial MCL, the posterior oblique ligament, which is part of your posteromedial corner, and the deep MCL. The other valgus restraint, so the ACL at greater than 30 degrees of flexion, and then semimembranosus and pes anserinus as well, tertiary or even further stabilisers. So the superficial MCL is primary valgus restraint. It's extrasynovial and articulate. It's broad, so its insertion points are listed there. The posterior oblique ligament, I guess, is one thing we haven't really mentioned as yet, but that's where we come into the idea of the stable at extension versus flexion. So it's not the oblique popliteal ligament from an anatomical point of view, don't get confused with them. The POL is a medial fibrous expansion, whereas the OPL, if you like, is the lateral fibrous expansion from semimembranosus. And its attachments are there just below the gastrotubercle, and the tibia is just inferior to the articular surface. And the deep MCL is essentially a thickening of the joint capsule. It has 2 parts, the meniscofemoral and the meniscotibial, and as we know, it's tethered to the meniscus. So biomechanics, the grey strain, as Andy said, is at the femoral attachment, which correlates with the commonest site of rupture. And in terms of valgus restraint for the knee, 0 to 30, it's actually the POL, which is the primary valgus restraint. And then more than 30, it's the superficial MCL. Obviously, the MCL has other important functions such as AP rotation and stability, but it's not part of the this talk. So in terms of pathophysiology, again, there's femoral, mid-substance or tibial tears. Femoral, the more common. Mid-substance, the ones that heal really well. With non-operative basic science, just to touch on that in terms of the pathology, hemorrhage, inflammation, repair and remodelling. That has an impact in terms of your prognosis, I guess, because in terms of the first 2 weeks, it's really hematoma converted to granulation tissue. This is any ligament repair. Matrix of immature collagen, that's type 3, is your scar tissue at 2 weeks, and then type 1 is the type of collagen that you want, and you want that organised in parallel, and that can take, that starts about after 3 weeks, but can take anywhere from months to years if you're talking about a grade 3 injury. Time to heal is dependent on the degree. Grade 1s and 2s, about 11 to 20 days, and grade 3s can take years to fully heal. So diagnosis, Andy's already talked about in terms of the history. Just a few other things from the reading that you want to think about is whether they've had any previous laxity in that knee, any problems previously, their functional goals as well. On examination, a few key points. You can actually localise the tenderness to help you decide where the actual rupture has occurred. Laxity at valgus stress, 0 or 30 degrees of flexion, again, is important for reasons we've talked about, and I'll go into a bit more. The idea of whether there's a firm endpoint. Now, these three things here, the Swain test, the anteromedial draw, and the positive dial test are all variations on a theme. That's someone performing a Swain test, knee at 90 degrees of flexion, apply an external tibial rotation. And the Swain test is that will elicit pain. The anteromedial draw is you'll get increased laxity compared to the other side. And the positive dial test, I won't go into, but you just need to be aware of the fact that the posteromedial corner will increase, will give you a positive dial test. So think about that when you're assessing for other injuries. Always look for other injuries, especially in grade 3 MCLs. And importantly, note the overall alignment. So if you've got someone that's already in valgus, like more than the physiological valgus, it has a bearing on how you're going to treat them in terms of how long you have them in a brace, for instance. Diagnosis, the X-rays and MRIs. Grade 2, and speaking to a couple of guys around town, grade 2 you'd be keen on getting an MRI for as well, not just the grade 3. So the X-ray shows the Pellegrini-Steeder lesion, the chronic MCL, and that MRI there shows an avulsion, and avulsions could be either bony or soft tissue. So classification system, now that we're here, the important thing is that it's confusing. Like the idea, everyone throws around grade 1s, 2s, 3s, and no one actually knows. I think if you got everyone in the room and asked them to have it, would be saying the same thing. And all articles acknowledge that this confusion makes subsequent comparison of outcomes difficult. There's one article that talks about 3 grades of grade 3 injury, and that's actually a JVJS review article. So the original classification comes from the AMA classification in 1966 of, I think it's sports injuries nomenclature, and they say the MCL injuries are classified based on the amount of medial joint opening when a valgus load is applied at 20 to 30 degrees of knee flexion. And that's what Andy was referring to with regards to 0 to 5, 5 to 10, or more than 10. So this is a little summary of the different things that people have looked at. So that first top line is essentially the original classification system, grade 1, grade 2, grade 3. And I've just put in brackets partial versus complete. That's another way of looking at it in terms of grade 1, 2, 3, the ligament itself. Whether there's an endpoint or not, grade 3 will have no endpoint. Whether there's laxity in extension. So extension, you're relying on your posterior oblique ligament in the posteromedial corner. So if that is gone, then you'll have laxity in extension as well, and that's more likely to be called a grade 3. So just management, I won't go too long into this, but prophylactic bracing, there's good prospective trials that show that that actually works to decrease MCL injuries, but there is a query of whether the protective benefit of it versus the functional compromise. Operative versus non-operative, most MCLs will heal with non-operative management. These are a few operative indications, Displaced avulsion injuries can be either bony or soft tissue. And the other one's the multiple ligament injury. The other ones to think about, chronic instability, Pellegrini-Steeder lesions, and open injuries. Grade 1s and 2s heal well, they're well vascularised, non-operative management. Mid-substance tears heal better. This is just a quick summary of what to do, so definitely rice them. Do not immobilise them for a long time, if at all, so it's very important. Early range of motion, Hinge knee brace, not for grade 1s, but probably for grade 2s I've written. There's no data that supports it either way, but I think most people would be putting grade 2s in the hinge knee brace. Anti-inflammatories, it's that age-old question of whether you use them. You want to bring the swelling down to get their range going, but you don't want to interrupt the healing. Weight bearing as tolerated according to pain. Ultrasound treatment is a good study that shows that increases type 1 to type 3 ratio, which is what you want. Get the exercise going on the quads and the hamstrings early, and return to sport once pain subsides and the laxity is clinically diminished. So there's a good basic science paper on the fact that immobilisation is bad for the ligament. It increases or decreases all those things. Functional outcome, again, good studies that show that grade 1s and 2s do very well. Average grade 1s returning to sport, American gridiron players, at 11 days, grade 2 at 20 days, so that's less than 3 weeks and they're back to sport. So this is one of I guess my take-home points would be that it's moving from this arbitrary number of, oh, you're in a brace for 6 weeks, to moving through the functional goals of rehab, and each patient's different. So you just assess them and see how they're going, move them to the next stage, so you don't have to necessarily be out for 6 weeks. Grade 3 injuries is where it's controversial. Originally we were fixed, everything was fixed. In the 70s we started treating them non-operatively. Indelicato has a landmark paper from '83. So he randomised operative to non-operative for grade 3 injuries. So he showed that operative were more stable to testing, but no functional difference. And that is repeated in multiple studies. So they are, there is more stability with operations, but there's no functional implication for that. And the other thing is that it's important to note that no patient actually returns to a normal MCL. So if it goes grade 3 to grade 2, then you're winning and you keep going with your non-operative management. So in summary, it's the commonest knee ligament injury and it heals well with non-operative. The classification system, I guess this is one of the most important things, is this is just a little spiel I came up with if you were given it in an exam. So you'd say grade 2 MCL shows 5 to 10 millimetres of medial opening. They have a firm endpoint with valgus laxity at 30 degrees, but not at 0 degrees of flexion. And you could say that posterior oblique ligament is likely intact or not, but something like that. And then, you know, I was just thinking like an examiner might come at you and go, oh, that's not what a grade 2 is, it's this. And I guess just acknowledging that there are differences would be a safe thing to do. So grade 1 symptomatic, grade 2 same as above, plus or minus a hinge knee, and grade 3 is non-operative, reassess at 6 weeks. Always get an MRI if you're worried about it.
Nice summary. So this is the stuff I really wanted to think about with the MCL injuries, and I think the problem with this classification of grade 1, grade 2, grade 3 really stems from these pictures here. This concept that you can have your sprain, you can have your partial tear where somehow things go like that and don't move, and then the complete tear where things really separate. And that's not how the MCL tears. And so I think that's been the problem with all these classifications, not matching up with the pathology. So if you examine this patient, they'll be stable. You examine this patient, they'll be stable. And yet that's a partial thickness tear of the MCL called grade 2 on the basis of pathology. It's only when you get to here that you're going to get any laxity, and that laxity will vary according to whether the posterior oblique ligament's been involved or not. So I think you've got to be careful when you're talking about whatever classification you're going to use, that you understand whether you're talking pathology, and then you'd use terms like it's a sprain or a partial thickness tear or a complete tear, which I'd probably try and steer away from. Or you're going to talk about laxity, and I think Matt's sort of suggestion of what a grade 2 injury is was perfectly adequate. I would probably put it to you that don't worry about grade 1, grade 2, grade 3. To me, they're stable, they're lax in flexion only, or they're lax in flexion and extension. And that's really about it in terms of how I think about it. I mean, yes, in my own mind, I sort of think there's a little bit of laxity in flexion, or a lot of laxity in flexion only. But the key thing is whether that posterior oblique ligament is intact, and that's the laxity and extension, or if there's no laxity at all. So you've got those at either end, and then you've just got the sort of typical ones that we're faced with in terms of decision making, which is some laxity in flexion but not in extension. So I think it's very hard to grade, 5 to 10 greater than 10, because is that in absolute terms or is that compared to the other side?
Yeah, and is it on valgus stress X-rays or is it?
Yeah, so is it? Yeah, exactly.
Examination.
And so I think that's, it's very difficult to sort that out. So I wouldn't get too tied up about the absolute values in terms of opening. Endpoint is sort of useful, but can be hard to assess when the patient's sore. So any questions about classification? I'm happy that we've got it. The principle. So then you get to management, and it always intrigues me because Andrew's presentation, the group comes up with, we'll put them in a brace for grade 2 injury, was it, or grade 1 and 2? I forget what it was, but I'm not sure whether that's just a guess or because that's what you've been exposed to, but it was exactly the same last time we talked about MCL injuries. You don't need to be too worried about most MCLs. They'll heal no matter what you do to them. I tend to not use any brace. The brace is fantastic for comfort, no question. If you've got any kind of ligament instability, put a brace on, it'll feel much more comfortable. But this idea of blocking extension at 15 degrees or 30 degrees, I mean, there's just no evidence as far as I'm aware to really back that up, that gives you better results. And certainly just from experience, it doesn't seem to me to make any difference whatsoever. You can have a Zimmer splint, you can have a knee, limited motion brace at blocked at various degrees, you can have neoprene supports with or without hinges in the side, you can have nothing. It all ends up the same way. An MCL injury will heal. If it's grade 2 or a 1, it's going to heal. Grade 3 are the ones where you have to think about it a little bit more. So I would put it to you that braces are really for comfort rather than to improve the absolute healing. And I think the point that medial ligaments like to be loaded, they like to be stressed to get the fibres all aligned. I mean, that's been well established in animal models. Probably worth talking about PRP. You're familiar with PRP? PRP got on the sports medicine map through an MCL injury. Pittsburgh Steelers player had an MCL sprain, injected, played Super Bowl, I think 12 days later or something. Would have had an MCL sprain, had tape, played Super Bowl 12 days later. But it's just worth being aware of PRP. I mean, it's being squirted around all around town, and MCLs is really where it's sort of got its traction in the sports medicine world. And I don't think there's any evidence to back it up, really. From a clinical point of view, there's some laboratory evidence that indicates it might be useful, but just to be aware that that's where PRP has been used. The other thing to talk about surgery is that you mentioned the alignment's important. So the valgus knee copes less with an MCL injury than the varus knee. If you're in Europe, there's a tendency to talk about operative treatment of MCL injuries, whereas here now, I mean, no one really operates on an MCL injury, but they still do in Europe. And one of the differences is soccer's their football, obviously, and you depend on a stable medial ligament to play soccer. You can't play soccer with an unstable medial ligament. So they're much more aggressive, and particularly in sort of higher levels of players. So there is a lower threshold to operate based on the sport. The interesting thing is that most soccer players that are any good are varus. It's very hard to play soccer with a valgus knee for the same sorts of reasons. So, worth thinking about. Probably all the points I need to make about MCL, unless there's any questions. So we'll move to combined ACL and MCL, and we've probably preempted some of that in the discussion. So, which group had that? But you can come and talk. So next time I'll remember to tell people to bring laptops to this session. Apologise.
So we did combined ACL. Sorry.
No.
Talking to the computer. My computer.
Oh, I don't have this one.
I did, yeah. Alright, need a microphone. So we don't have any fancy slides, but we did combined ACL and MCL injury, and there's a reasonably good, I think it's fairly recent JOS article that talks about MCL injuries, and they come up with a fairly good protocol for managing combined injuries. And basically what they talk about there is regardless of the injury, you brace them for 6 weeks. So functional bracing, full range of motion, full weight bearing, as we said before, because it likes to be stressed. Quads and hamstring exercises. Reconstruct the ACL at about 6 weeks or whenever they get their range of motion and strength back. And intraoperatively, after the ACL is reconstructed, you stress the knee in full extension at 30 degrees. And if it opens up more than 4 millimetres in either full extension or 30 degrees, then that's an indication to reconstruct the MCL. What we sort of talked about before was, would you possibly give them an examination before you did the ACL? Because obviously you're going to have graft considerations, and if you've used hamstrings to do your ACL and you get to the end of the operation and they're opening up 5 mils, you have to dig the other leg out from under the drape. So we sort of threw out maybe, because it seems fairly cut and dry to me that you would treat it conservatively, brace them, do the ACL and then assess their MCL. So as a discussion point, would that be an indication if you had a very lax MCL prior to doing your ACL on the table, would you then maybe think about doing a bone patella bone ACL, so that if at the end of the operation you do open it up by more than 5 mils, you can then grab your lateral hamstrings and pop them onto your MCL. And if you were going to reconstruct the MCL, the isometric point on the femur they talk about is a centimetre anterior and distal to the adductor tubical knot right on the femoral epicondyle, as I probably thought before I'd read that article a while ago.
Good point. I won't answer it at the moment. Let Matt talk about it. So, are you saying that any combined MCL, ACL, you're going to put them in a brace for 6 weeks?
No. Have you got any? Are we talking about further injuries, like multi-ligament knee injuries?
No. Just assuming that it's ACL, MCL is a combination. What I'm getting at is any grade of MCL automatically needs 6 weeks in a brace before you do their ACL?
Oh, no. I'm talking about grade 3 MCL and ACL.
Okay, what about grade 2?
So grade 2, like you said, I think if it's pain relieving, and I think I would have thought there's some logic in keeping your MCL relatively stable whilst it's healing up. If it's constantly getting a valgal stress and being stretched out, I would think that it would sort of, the fibres wouldn't quite align across. They talk about, percentage of type 1 collagen versus type 3. So 1s and 2s are supposed to heal by type 1 collagen, and 3s is type 3 because you've got a gap that's got to fill with scar. And if you're keeping it nice and stable in a grade 2 and you're keeping the fibres well together, then do you get more type 1 collagen healing, which is more beneficial? Type 3, I don't know the answer to that, but logically it seems to me that yes, I would brace it.
Don't forget, when you walk, your weight-bearing line goes through the medial compartment.
So you've got a varus moment.
You've always got a varus moment. Yeah. So it's, unless you're really valgus, you're unlikely to be opening up your medial compartment. Okay, thanks. Matt? Really common problem, combined ACL and MCL, and it's made more common by MRI reporting. So lots of people coming with ACL, MCL. You know that their MCL isn't much of an injury, but you've got to have a strategy for dealing with it.
As always, I agree with most of what Dr. Gomez has said. Overview, 80% of grade 3 MCLs have concomitant ligament injuries, and 95% of those are ACLs, so you've really got to look for them. O'Donoghue's original triad was ACL, MCL and medial meniscus. That was subsequently shown to be a lateral meniscus, 3-to-1, so it's lateral 3, medial 1, by Shelbourne in 91. And for those Geelong fans out there, that's Menzel doing his ACL on Friday, and I think if you look at the video, you can see him going to a fair valgus. His knee going to a fair bit of valgus. So Mr. Feller asked me to look into ACLs in combination with 3 types of MCLs, so plus inflection, zero extension. I think that's probably just the giveaway of how Mr. Feller looks at grade 1s, 2s and 3s, because it's, after a few days I got my head around the fact that that's what he was getting at. Grade 1 MCLs, as you just said, no valgus laxity, managed as per the ACL. Grade 2s and 3s is where the controversy comes. So literature not supports everything, reports everything. So not for both, opt for one, not for the other, or operative for both. And there's a few little things to think about around that surgical decision making. Bear in mind the indications for acute MCLs. avulsion open and chronic. Yeah, so just some biomechanical data. The MCL doesn't like having an ACL deficient knee. It needs that. It does need movement and does need weight bearing, but it also needs that AP stability. So it's been shown the ACL deficient knee leads to increased valgus laxity and decreased tissue quality of a healed MCL. That's in both rabbits and dogs. Conversely, the MCL deficient knee has an effect on an ACL graft. So lab data shows that there's increased force through an ACL graft if the MCL is missing. And there's clinical data that shows that objectively there's increased laxity in both the AP and the medial lateral plane when a ACL is fixed and the MCL is treated non-operatively. However, that paper didn't discuss the clinically implications of this. And as I've already talked about, the examination findings don't necessarily equate to functional impact. So operative MCL, they've also showed that the MCL in rabbits, when you operate on them, it's structurally sounder or more sound at 12 weeks, but at 1 year there's no difference between operative versus non-operative. Grade 2s and 3s, and there's a few things that Glenn's already talked about. The other factors to think about is when you do the operation, whether you do it early or at 6 weeks. If you do decide to fix the MCL, when do you decide to fix it? Pre or post ACL fixation, just as Glenn said. And also, I guess, pre or post operation. Do you decide in your rooms at 6 weeks, or do you decide once you've got them on the table? The effect of using ipsilateral hamstrings on medial stability, albeit a tertiary stabiliser, but still a medial stabiliser. The post-op rehab, is it any different in someone that's had an MCL, apart from the fact that you will hinge knee brace them? And is the MCL actually repairable at 6 weeks, or do you have to go in there with the intention of reconstructing it? Most literature would say that you go in there with the intention of reconstructing rather than repairing. So there's risks associated with timing. As we know, early you run the risk of arthroplasty, subsequent range of motion issues, and delayed you run the risk of that suboptimal healing of the MCL, as those biomechanical studies have already shown. So the JOS article was mentioned, and it actually contradicted itself a little bit in the article. So in the body of the text, it said that we believe the benefits of optimising the environment for MCL healing for a biomechanical standpoint outweigh the risks of arthroplasty. Essentially, operate early on the ACL because that has a benefit on the healing MCL. But then they go on in their author's preferred method of treatment to say that they use the term prehab in other articles. So rehabilitation for 6 weeks in a brace, and then assess the ACL on table, the MCL rather, on table after doing the ACL, and reconstruct if required. If it opens up, sorry. 30 or 60. The ABGS article didn't comment on specific indications for when to fix the MCL, but interestingly enough did say that you should, if you do decide to fix the L, do it shortly after the injury, as in sooner than the 6 week mark. The American Journal of Sports Medicine also had a review article on the topic. Good short-term results have been reported in non-operative management of the MCL, but long-term results are lacking. 4 to 6 weeks of this prehab has been recommended again, focusing on range of motion, focusing on getting your knee out extended, and then do the ACL reconstruction. And they apply a valgus intraoperatively after reconstruction of the ACL. So the question of whether grade 2s and 3s need to be treated differently to each other. A paper from Millet examined 18 patients, and they did an early ACL recon and treated the MCLs non-operatively. Grade 2s and 3s had no functional or activity level difference in follow-up. And then if the MCL is to be fixed, when should this decision be made? You've already talked about using the hamstrings and bone patella bone, but also the idea of forming your ACL and then making your medial approach harder with the extravasation of fluid, for instance, putting at risk structures such as the saphenous nerve and vein. This is a nice paper. I like this because it's actually level 1 evidence. So it's prospective, it's randomised controlled trial from Finland. They looked at 47 consecutive patients with ACLs and grade 3 MCLs. They did non-operative MCLs in non-op versus op, and they randomised that. And they reconstructed the ACL, importantly, in the early phase. So no one waited longer than 3 weeks. The ACL was fixed within 3 weeks in all of them. They used bone patella bone, and they did an open MCL if that was what was randomised to. They excluded all other injuries, PCLs, LCLs, grade 1s and 2s. Meniscal injuries they left in there, common anyway. and the post-operative they arranged them and weight beared them, but they did put them in a brace from 6 to 8 weeks. 6 weeks completely, the 6 to 8 week mark when they were walking. So the findings were excellent follow-up for 2 years, 100%, and they found no significant difference in the groups with regards to range of motion, which is your worry about doing things early, AP displacement, quads function, or any of the functional or activity scores. The only difference they found was essentially on examination, or rather on radiological investigation, and the valgus stress x-rays. These are actually, oh no, that's been fixed, that's good. So group 2 is the non-operated. There was a significant difference between the non-operated and operated in that it opened up further. However, the side-to-side difference was not significant. So in summary, grade 1s managed as per the ACL. Grade 2s, you could argue, equal grade 3s with regards to the problem in terms of reassessing them. The JS and AJSM say they're pre-habit for 4 to 6 weeks, assess the MCL after reconstructing the ACL. But there is that alternative out there of reconstructing the ACL early and non-operative for the MCL. So I thought just in terms of further studies, you could take it a little bit further and go with your non-operative for 6 weeks and then reassess it. And then if you still find it to be open, then randomising them into operative versus non-operative, because now theoretically you're giving the MCL the optimum environment to heal with a stable A to P. Obviously that would take a few years, if not decades, to create the relative powers. And as a Melbourne supporter, I did a little bit more thinking during the week, and I thought about another biomechanical study. I thought we could look at the some related to this. The loading forces when $6 million is applied to the injured patellofemoral joint of a 20-year-old AFL footballer. The hypothesis is you have no wins, wooden spoon, you'd be living Western Sydney, you get trounced week in, week out, but the $6 million would probably make you feel pretty good. I don't mind that, draft picks are good.
Oh, I was going to say, but grade 2 Friday draft picks and improve the football.
Should be more.
It's good. I think reading the literature makes it hard because, I mean, particularly the American literature, and there's all this bracing and surgery. And just to put in some kind of perspective, I do roughly 250 primary ACLs a year, 30, 35 revision ACLs each year. The number of medial ligaments I have to address surgically, maybe a couple of years. So, you know, it's not a common problem. I take a much more sort of laid-back approach in terms of the MCL. From my point of view, it comes back to no laxity, laxity and flexion only, laxity and flexion and extension. No laxity, so it's a sprain if you like, doesn't matter what it looks like on the MRI, if it's stable, it'll be tender probably over the medial femoral epicondyle. For me, if you treat it as the ACL has been suggested, but it's really important that they restore their extension prior to surgery. This is the group that struggles. And you see them a lot in skiing in winter, so the sort of novice skier who collapses into a snowplow and just gets bilateral valgus injuries. They're the ones who you just have to really work hard at and say, no, I'm not going to operate until you've got extension. And you can have tears, you can have whatever. You've got to stick to your guns, because every time you don't stick to your guns, you regret it, because they come back and at 3 weeks, post-operatively, not quite straight. 6 weeks, still not quite straight. 3 months, you know they're never going to get quite straight. And they're never going to get happy because their quads will never function in the same way. I saw Classic yesterday. I mean, she should be motivated. She's a phys ed teacher. You know, she was 0 to 100 or whatever when I first saw her, and I sort of gave in and operated on her. And 0 to 100 sounds okay, but that was 3 degrees loss of hyperextension compared to the other side. So I thought I was, should be all right. Post-operatively struggles to get full extension, and now she can just get out to sort of maybe 1 or 2 degrees of datum, but she's never really got her quads going. And you can see that the whole progress has been slowed because I didn't insist that she came back with good active terminal extension into hyperextension before she had a surgery. And so if you're going to ignore that MCL injury and just go with the ACL, you still have to stick to your guns about getting extension and probably be more diligent than you would be if the MCL wasn't injured. So that's group 1. Group 2 is the laxity and flexion only. And that will vary a little bit the amount of laxity, but the majority of them, sure they open up, it can feel quite dramatic when you first do it. The patient gets a bit frightened by the feeling and tenses up, but then you just get them used to it, and they realise that there is a bit of an end point. So for that, I just basically ignore it again. The MCL, it's going to heal. I want to keep making the point, MCLs will heal, they just want to heal. And so I'll go through the same thing, just get your knee straight, get your knee going. When you're comfortable, we'll do your ACL. If you want to wear a brace, that's fine, but I don't brace them. I don't prescribe a brace, it's just if they want one, if they've got one. But I emphasise extension, I don't keep them locked in flexion. And so it's really only that third category where they've got laxity and extension where I change my management. And there I'll go quite the opposite way. I'll do an early ACL, do the ACL reconstruction, fix the distal end, and then re-examine. And if they're back to my sort of typical grade 2 ACL, if you like, if they're only a little bit of laxity or no laxity in flexion and they're completely stable in extension, get them going. I don't use a brace post-operatively. They've had their ACL, that's a pretty good brace, and they'll be a bit sore anyway. Just get them going, emphasise extension, because if you don't get extension back after ACL, you'll never have a happy patient. And that then just the sort of the part B of that group is those who are still a bit lax in extension at the end of the ACL, or they've got significant laxity in flexion, and they're the ones I'll repair. But if you repair, you're going to really increase the pain levels of your patient. They're the ones who go stiff, and it's dramatic. One of the AFL players earlier this year where I did repair their MCL, and he struggled with stiffness the whole of the season. I mean, he's fine now, but it took a lot of work to get his range of motion back. I'd much rather just have ever so slight laxity in flexion than a stiff knee following an ACL. Got good extension, got good quads, I'll be much happier. So
Actually repair rather than
yeah, because I go in early. Then I go in early. So it's a definite repair. And you've got to map out where the tear is. And that was one of the points I wanted actually to go back to in that diagram. The best diagrams I've seen of illustrations of how the MCL tear come from Werner Muller's book, The Knee. Old, but he did a lot of open surgery, so he's got really beautiful illustrations of all the patterns of tears. And you see that it's not this sort of thing that just goes straight across, it works its way in an oblique fashion. It might start up at the proximal attachment and work its way forward or back, and it really depends how far it goes as to how unstable the knee feels. It's not that sort of, is it that or that or that? It's more, is it that or that or that? So it's how far the tear extends forwards and back that gives you the laxity. And as for reconstruction of the MCL, really